All right, welcome everyone. We are going to get started here. I'm first going to pass it over to Vincent for some opening remarks.
Hi, thanks, Michaela, and thank you all, and good evening. Thanks for joining us. I'm Vincent Atchley. I'm the CEO of Mental Health Colorado, and Care Not Cuffs is our national initiative to disentangle mental health and criminal justice. And one of the main things we're aiming to do is put a spotlight on important and valuable work that people are doing all along the whole sequence of interception with individuals in need of mental health care and support. And I'm currently in transit and driving, and so I'm going to limit my remarks to that, and just thank Michaela again for orchestrating this, and for Dr. Gonzales for being with us this evening. So back to you, Michaela.
Amazing. Thank you, Vincent. So hello all, and welcome to Care Not Cuffs Monthly Dispatch. Each month, we invite presenters from around the country to share their work at the intersection of mental health and mass incarceration and the ways they are building safer, equitable systems of care for those facing mental illness, substance use, and justice involvement. We would like to recognize and thank Rocky Mountain Health Plan's Mental Health Colorado's elite sponsor of the year. I'm Michaela Whitley, and I am the program manager for Care Not Cuffs. Thank you again for joining us. This evening, we are thrilled to have Dr. Tina Gonzales sharing her work with CareLawn, supporting the justice-involved population in reintegrating into their communities in southeastern Colorado. Dr. Gonzales has over 18 years of experience in program management in healthcare, behavioral health managed care, and healthcare within the criminal justice system, ranging from conceptualization to implementation. She has worked to create sustainable healthcare programs for justice-involved populations while supporting the workforce in this healthcare delivery. She has enhanced data sharing capabilities at this intersection through bridging stakeholders and technologies, and has advocated for Colorado's vulnerable populations through a variety of state-level work groups and task forces. Dr. Gonzales is passionate about eliminating health inequities and building practical healthcare homes and reentry programs. Thank you, Dr. Gonzales, for sharing your work and expertise with us this evening. There will be 10 to 15 minutes for questions following the presentation. We invite you to use the Q&A feature to ask questions throughout. And with that, I will turn it over to Dr. Gonzales to get us started.
Thank you. And I'm going to, Michaela, share my screen. But once I do so, I will not be able to see you. So if something comes up, or if you can't see or can't hear me, you'll have to speak up, because I won't be able to see anyone or you for any cues.
Absolutely. I'm sure it'll go swimmingly.
So on your Zoom, where is it? Oh, there it is. I found it. Awesome. Are you able to see it?
We can see your screen, but I don't currently see. Oh, there we go. We got it. Oh,
there it went.
Yep. We had it for a second. There we go.
Awesome. Awesome. So again, I am Tina. I work with CareLawn Behavioral Health, and we are actually a nationwide organization. Recently, we were purchased by Anthem, so you may have known me if I've worked with anyone in the past as working with Beacon Health Options. We are now CareLawn Behavioral Health, and I want to go over or really share with you some of the supporting work that we have in building justice-involved building programs for our justice-involved individuals and kind of successfully reintegrating them into the community across our contracts, but specifically with Colorado. So for today's discussion, some of the objectives is really going over the importance of working with justice-involved individuals with behavioral health and our developmental disabilities. explore the challenges and barriers behavioral health care providers may face while working with justice-involved populations, and some of the Carillon solutions that we have built to support our clients working with our behavioral health populations, and identify effective strategies and programs for working with justice-involved individuals cycling through the Colorado criminal justice systems. And just to give a quick overview of our footprint in Colorado, back in 1991, we were known as Value Options. So we have been doing business in Colorado in different capacities since 1991. I joined Value Options in 2013. 2014 is when we transitioned over to the Beacon Health Options name, but none of the programs changed, just our naming changed. And at that time, Beacon had partnerships in some of the behavioral health organizations and the regional care collaboratives. So those were predominantly the Medicaid health plans back in 2014. So Colorado was divided into 5 different regions for behavioral health care and 7 different regions for the regional accountable collaboratives, which really looked at the physical health side of Medicaid. And so Beacon was partner in the Colorado Health Partnerships, which was the largest in landmass of the BHOs. So we covered 77% of Colorado, as well as the Foothills Behavioral Health Partners, which were the Denver metro area, so the Boulder Jeffco area. And then we were also partners in one of the regional one of the RICOs, and that was in the Southeast region, which was the Integrated Community Health Partners. In 2017, the health plan shifted, and so did Medicaid. So they really merged the RICOs and the BHOs into one health plan. They got kind of put to rest the RICOs and the BHOs and created the regional accountable entities, are the RAIs. So currently, under the Carillon kind of brand, we are partner in the Colorado Health Partnerships. I mean, the Colorado Health Inc. or HCI. I will probably be referencing it throughout this presentation, which is the 19 counties in the Southeast. And then we are a delegated entity, so we're not a partner, nor are we part owner of the Northeast, but we are delegated some services or some roles within the Northeast Health Partners. Throughout this presentation, though, I will be sharing some data specifically from our Colorado Health Partnership BHO and our Health HCI RAI, just kind of moving forward. And so long history, and a lot of the work that we developed for criminal justice really started back in 2014 with the BHOs. And so looking kind of at Colorado and kind of just across the nation in general, there are similar trends and common themes that we kind of see throughout with individuals who enter the criminal justice system. So whichever intercept they're at, 0 or 5, Carillon has built interventions to try to help create some of those therapeutic jurisprudence interventions that could take place depending on where they are within the intercept, with the goal of preventing further further involvement with the criminal justice systems, or identify individuals who may not need to be in the criminal justice system, but may need to be in treatment. And so some of those challenges for individuals with mental health, substance abuse, or developmental disabilities is, of course, they're overrepresented in jails and prisons. It often destabilizes them, kind of interrupts their employment, their housing. In Colorado, it does interrupt their Medicaid health plan because it does get suspended. And it also kind of triggers some individuals who have the mental health or the substance abuse challenges, and they often stay longer in the jails just because they're having issues trying to get out or finding services that can adequately sustain them in the communities. And of course, there's a high prevalence of trauma. Upon release, they are at a greater risk of reincarceration, emergency department, hospitalization, homelessness, and death by overdose. And so I have death by overdose kind of underlined just because in Colorado, that is actually one of the governor's wigs. And really one of the populations that has really gotten a lot of focus and tried to build interventions and support to kind of prevent or reduce some of that death by overdose or accidental ODs. In the middle, this is from HCPF, who is the state entity that oversees the Medicaid health plans. And so they kind of did some research and some work just to kind of identify the prevalence of individuals in our criminal justice system who have SUD or opioid use disorder, and kind of some of the statistics around kind of what that looks like in terms of needed interventions. With the county sheriffs of Colorado, since they're all different and they're all managed by the sheriffs, currently the health plans in Colorado are not measured by the success rates that we have or kind of those collaborative efforts that we have with the jails to help with that continuity of care or to help identify folks who are coming into the jails who might have this need. However, with Department of Corrections, the health plans are kind of monitored. And every single month we do get, actually it's quarterly now, it used to be monthly, but now we get it every quarter. Kind of the trends that HCPF has seen for individuals who are releasing from Department of Corrections and how fast they are getting into some of those medication assisted treatment programs and treatment. So they look at it at 14 days beyond their release, were they in treatment within 14 days, or there's also a 30-day metric. So the Rays were kind of scored on that as a collective group. And so, but they also kind of share with us what region is kind of focusing and kind of what our success rate is and maybe where there might be some needs out there for the county jails and for the prisons. But across the nation, there is discussion currently about the new 1115 waivers. And those waivers are actually supported by CMS. And what those waivers are, the 1115 Medicaid reentry waiver, is it would allow individuals who are getting booked into a county jail who have Medicaid to actually have that Medicaid reinstated 90 days prior to their release. And so some of the work, so when Carolyn kind of saw this and saw that across the nation's kind of a lot of the states going after this, we were very excited because we have kind of built the infrastructure to support states. And some of our clients that we actually work for directly are the states. One of them being California. So California was the first one to get approved. Carolyn actually owns one of the Medicaid health plans out there. So a lot of the work that was really innovative and developed and facilitated here in Colorado will actually now be applied in California, as well as Washington, which is another one of our states where our client is the state itself. And then this map kind of shows the ones that are pending and approved. This, even though I just got this at the beginning of the month, has already been updated. So a lot of the other states who were pending have now gotten approval. And so some of the work that we are doing at Carolyn and kind of introducing what we're doing in Colorado is with California, Washington, North Carolina, Illinois, Maryland, and soon to be, I believe, Penn State. So what the program that we have developed specifically for the county jails in any state really is a product called Justice Connect. And so this program kind of supports that continuity of care to address mental health and substance abuse concerns, improves the discharge planning to increase adherence to follow-up care, successful reintegration into the community, and reduction in both state and correctional facility recidivism. So kind of looking at our states across the country and looking at kind of the successes that we saw here in Colorado. Some of of course, the timeline of really identifying what the issues were, talking to states, and kind of hearing their pain points and kind of knowing that some of the pain points that they had, we also had here in Colorado, and we're developing programming around individuals who were justice involved. And then we brought some of the solutions and some of the data that we had to kind of share, and then really kind of started building those objectives on what's going to work. So some of the data that we do share, like I said, was kind of developed and implemented here in Colorado under the Justice Connect program. So we started it in 2014 and it ended in 2020, and I'll go over that in just a second. However, we took this product from our Maryland contract, who really dived in to some of this programming in 2009. So we kind of took from their genius, developed it around Colorado, and kind of implemented the program. And so what is Justice Connect exactly? So what this is it was the first ever, I believe, in Colorado, data sharing technology that allowed us to identify our membership who was getting booked into a county jail, who had a behavioral health service prior to their booking. So what that does is we would upload our entire adult member Medicaid membership into a secure site, working with a vendor who had access to jail booking and release records. What we do is we upload that monthly, and every single day, if anyone on that roster has a jail booking event, it will flag them and deliver that to us. And when I say us, it's Carolyn. And so once we compile all of the arrests for that day, what the Justice Connect system then does is it will start bumping it against Medicaid behavioral health claims and encounters, and it will kick out the ones who actually are flagged as needing that continuity. It will then build a member demographic, which then goes out to both Carolyn, so that we can kind of keep track, our local detention center, as well as our care coordination entities who are helping us to do in-reach into the jails, to connect with individuals and to see what their needs are, and then try to work and advocate to get them out of the jail and into treatment. And so simultaneously, while all that's happening, Justice Connect will also go out there and pull any pharmacy data for these individuals, so that that continuity in pharmacy is continued in the jail and on the way out during their transition planning. So we started this program, like I said, in 2013, but really went live 2014 when we, which was full development under the BHO contract. And it continued until 2020. When we were kind of looking at some of our statistics in 2017, when the BHOs transitioned into the RAYs, this program kind of followed into the RAY contracts. And so we were looking at the significance and what we were able to do, and the lives we were able to impact just with this data sharing technology and capabilities. So Justice Connect, acting as an early alert system for Colorado's care coordination intervention, and to kind of support some of our clients here in Colorado in identifying our membership. I think the biggest, and it was interesting that it was not created to do some of the impact that it did do. It was really created as that access to care. Once we alert, we get them into treatment after they get out. But when we started looking at the data and looking at those who had a mental health diagnosis at booking, the system, we were able to show a little over 20% decline in the average length of stay. And so in 2013, as you can see, they were staying 28 days, kind of the medium stay was 28 days. After this was implemented and we're able to flag and actually see these individuals, the length of stay for individuals booked with the mental health diagnosis fell to 13 days. And so being able to get those care coordinators in there, kind of advocating and setting up services. So to us, that was a huge win. And then kind of looking at the 4% decline in the rate in which members were being booked. So it didn't eliminate them being booked, but it did kind of decrease somewhat of individuals actually with a mental health diagnosis being booked into the county jails. And so this was under the BHO contract and kind of some of the work that we were doing there. Like I said, we rolled it straight in to the transition to the RAYs. And really, since the RAYs started to integrate some of their care, instead of just flagging those with the behavioral health behavioral health service prior to booking, we looked at kind of the physical health as well. However, since this was really an intervention for behavioral health, some of the statistics I'll share are really kind of around that behavioral health diagnosis. And so in 2017, the raise, like I said, they launched, the contracts were awarded. And so Justice Connect kind of rolled into the Ray contracts that Carolina was supporting. The data on the right is for Region 4 only. So that's the HCI 19 counties in the Southeast. As you can see, we continue to see a decrease in the number of members that were actually being booked. And the number of individuals who had a behavioral health diagnosis at booking. We looked at that to see how many individuals were in a post-release treatment service within 30 days of their release. And so as you can see, from 2017 to 2019, that continued to increase as well. So once we identified them, got those services there, we were able to track them when they got out and their Medicaid health plan was reinstated, and we can actually track where they were going. So all of this work was done pre-COVID. And then in 2020, when the COVID pandemic hit, unfortunately, Justice Connect was one of the programs that we had to stop just because all of our finances and kind of focus turned to the pandemic itself. However, we were still able to kind of look at some of that data. And when I say we had to stop Justice Connect, I think it was the right decision. Just as you can see, the jail booking events in 2020 actually declined by almost 50%, over 50%. So the sheriffs were not booking people into the jail if they did not need to be there, just to kind of help contain the spread and kind of eliminating the COVID coming into the jails. However, what we did see when we were looking at the data, which is something we had not seen in all of the years that we were facilitating this program, was that individuals who were being booked with the behavioral health diagnosis had a behavioral health diagnosis pre-booking, we had more individuals getting a behavioral health diagnosis and getting into service post-booking. And so we haven't really dived into that data just to kind of see, but there's a few hypotheses that we have that would kind of relate to why we saw that spike in individuals getting diagnosed after release. But really no real concrete kind of data dive has been done. It was just interesting when we saw that. And then in 2021, again, we saw the decline in jail bookings. However, it's still the increase of individuals with a behavioral health diagnosis and a behavioral health service post-release. And so, like I said, we had not seen that. So that was really, really interesting. One of the if you want to call it a benefit from the pandemic, what we saw is the American Rescue Plan Act, or the ARPA funding. This was funding that the federal government gave to the states. Governor Polis decided to utilize some of this money to really enhance some of our behavioral health services and our high intensity behavioral health services. And so when our HCI partner received this funding, we saw a way to bring our Justice Connect program back and to really utilize it to its full extent. And so we kind of looked at the data to see what we have been able to do and where else we can kind of utilize this program and what other populations it might be able to support. So I'm going to try, let's see if it works, to share a video. During the pandemic, I actually saw this news article on KRDO. So I wasn't involved with the case and I don't know the family. However, after seeing it,
Police statement saying that he was a teammate and friend of the Army has grounded all beyond appalling how her son died in a Mesa County jail. Well, today we learned Mesa County has agreed to pay a family $2 million and the death of their son. He died of an epileptic seizure while in custody and was neglected by deputies. Our investigator, Brian Moss, has been following this story for years now. Joins us to explain how this is all unfolded.
We've communicated today with Tomas Beaufort's mother. She calls this a partial win, as the Mesa County Sheriff is apologizing for what happened and says reforms have been instituted. Tomas Beaufort was 24 years old, lived with developmental disabilities, and had the mental capacity of a 6 or 8 year old. He'd been living in a state facility in Grand Junction, but was moved to the Mesa County Jail on assault and sexual contact charges in 2014. But as we reported in 2016, jailers would not allow him to keep an anti-seizure device with him in his cell. The coroner says he died of an epileptic seizure.
Seizures are a real disorder. If you were having a heart attack, they would have called 911. If you were having an asthma attack, they would have called 911. But he had a seizure over and over and over again, and they let him die.
Many jails have told us that they allow inmates to have these bracelets to trigger their vagus nerve stimulators, but Mesa County would not. Now, the Sheriff's Department will also be placing a plaque at the jail remembering the life of Thomas Beaufort, and that plaque's going to go up on his birthday in July, and that means a lot to his mom because it's going to remind people who work at the jail, she says, that he was a human being and remind them the people there are humans.
So sad.
Yeah, it was a heartbreaking story.
Yeah.
So, like I said, I saw this story late last year. And so, of course, my brain goes straight into problem solving and kind of being solution focused and realizing that we had access to some of this data and try to figure out how we can support our sheriffs and our jails and our members with disabilities who are also being booked into the county jails. That was something that we had never looked at before and really didn't do a real data dive just to kind of see the prevalence of individuals. While looking through that, we found the disability response teams that were created through the Center on Criminal Justice and Disability. And so looking at some of their modules and kind of some of their mission and some of their visions, and really looking at the representation of people with DD in the criminal justice systems, it really brought together the professionals from disability and criminal justice to share their expertise. And so that was something that we had not seen done here in Colorado. And so we kind of were curious if what that data would look like if we actually kind of pulled it and were to look through it. And so all of us have access to our member eligibility rosters. And in those rosters, it will tell us if a member is a patient with a disability, if they are receiving home and community-based services or HCBS services in Colorado, which are the waivers that provide supplemental services beyond the regular Medicaid health plan. And so we looked at those members who met the definition for an individual with a developmental disability. And pre-COVID, during COVID, so 2020, 2021, we looked at that data and we bumped it. And we found that 50% had a primary diagnosis of behavioral health, while 14% of those individuals were individuals with a primary diagnosis of DD or IDD or some other disability that we were able to flag. So of course, we pulled that into our data, and with some of the funding that we got from the ARPA grants, we brought back Justice Connect, but we added a flag to flag those with disabilities so that we're able to provide some of those supports, some of those wraparounds for a new population, a new target population, to see if we might be able to impact and maybe avoid some of what happened a few years ago. And so currently today, 2023-24, our Justice Connect data and our treatment teams look a little bit different. So the member demographic, which also includes the jail booking charge, is included in the profile that Justice Connect creates. Previous provider, any pharmacy data, any disability services, HCBS services, if they're getting services from a case management agency, who that agency is, the waiver type that they might have, and their diagnosis. What this also does is if we do have an individual who has a disability and no HCBS services, we're hoping to work with our CMAs a little bit closer to start doing some of those referrals or eligibility to see if individuals just maybe were never educated that there was an HCBS kind of system out there. And if they are eligible, can kind of start the process of getting them onto some of those waivers while we're kind of doing some of the continuity of care with some of their other services. The treatment team now, of course, the care coordinator or navigator, whoever is working with that member pre-release. On the booking charges, in the event that any charge turns into a parole or a probation violation, we make sure that we are communicating with them, that we are working with the member and trying to access services and get some community supports. And then we also, if a provider or clinician is also working with the member and wants to be involved or part of that treatment, when they're getting those referrals, of course, we bring them in. And then, of course, our case management agencies, like I said, we hope to kind of build some of those relationships with this new population of bringing disability world and criminal justice world together to work on the same treatment plan with us for these members. And so that was, I think, one of our biggest wins with Carelon in developing and actually bringing and utilizing a data sharing platform that really works with the judicial system. So whether it's probation, whether it's the courts, whether it is at the jail level, we're able to identify these folks and ensure that we are working together with everyone involved in their care or with their transition. So we're looking forward to 2024 to see where this program can go. And so this is just one of many interventions. We also work with Department of Corrections. Some of the work that we started with Department of Corrections started back in 2014 under the BHO. This is an older map, but I did utilize it just because it does reflect. Back in 2014, sorry, we were actually working with 19 of the then 20 facilities in Colorado and the 2 private facilities. And there was actually 3 back in 2014 when we started working with individuals, where we were actually going into the prisons and doing some of that Medicaid inreach and education. 2013, when the Affordable Care Act kind of kicked in under Governor Hickenlooper, he did carve out a Medicaid kind of health plan specifically for individuals who are releasing from a correctional facility. And so what we found right on is that individuals who were not historically eligible for Medicaid were now walking out of a prison facility with Medicaid in hand. And there really wasn't that education on how to utilize it, where to access services, and what services Medicaid would and would not cover, and kind of that gray area of the criminogenic risk versus the Medicaid medical necessity component of Medicaid. And so really building that program and building some of that education so that we can start working with our members. Back during the BHO, like I said, we had 48 of the 64 counties in Colorado. So we were fortunate that the Department of Corrections, the prison facilities, were willing to work with us and allow us to kind of develop this inReach program. And so with that, we are actually taking this program across the nation, California, Washington, some of the states that I had mentioned, just to kind of build that collaborative partnership, which is crucial for any program to really work, and to kind of help that seamless transition back to the community for the member, if you have buy-in from kind of all entities that are responsible for this individual's well-being and for their care. And so working with the reentry pods in Colorado, the reentry pods have been changed naming convention depending on kind of what programs Department of Corrections is bringing in. However, we do have relationships, like I said, with all of the facilities except for one currently. And today, post-COVID, we are building back up our relationships, but we are currently in only 8 of the facilities doing Medicaid inReach. And we're able to connect with individuals 90 days prior to their release and kind of start some of that transition planning. Monthly sessions are held to kind of discuss the Medicaid benefit and start building some of those relationships with individuals. It goes from the project coordinator who is in the prison, usually that's me, or funnels it back out to the care coordinator in the community. And so that introduction, that relationship building is really huge to kind of build that rapport. And then we're seeing the success of them actually getting into staying engaged into treatment on their way out. Earlier, I shared the metric from HCPF. That was for the medication assisted treatment. we as the Rays, and there's 7 of us plus Denver Health, we are measured on this as a collective group. So in the event that we meet a specific target that the state has given us in getting individuals releasing from a prison facility into treatment within 14 days, I think every single year we have met that metric, like I said, as a collective group. So all of us have different interventions on how we engage individuals. We have just elected to continue going into the prison to work with individuals pre-release and kind of identifying those. And then the data reporting kind of just supports that it is working and that we are able to continue doing that program. So some of the Medicaid InReach, Department of Corrections and HCPF, who HCPF, like I said, is over the Medicaid contracts. They actually assigned a data sharing agreement between those 2 entities, knowing that that data would be passed down to the Rays. And so every single day we get a daily release roster, all of us kind of together. And then from that, we then identify members with the behavioral health or a primary care need and are actually releasing or were sentenced out of one of our counties, because that will kind of let us know who's going to be returning and who we need to start working with. Again, that InReach, the educational sessions with members to start some of that transitions of care planning, the continuity of care, referrals, appointments within 14 days of their release, and then those warm handoffs to care coordination. And so that continuity of care also incorporates that wraparound. So if they're needing transportation or education on how to get transportation to and from appointments, if they're needing transportation from the facility to their housing program, kind of working with some of our community-based organizations who have funding that can support that. Really, that community helps us with that, with those warm handoffs and those wraparounds. So like I said earlier, post-COVID, we're only working with 8 facilities now. I am hoping to get into the rest of them before 2024 is over, so that we can kind of continue doing some of this work. And as I mentioned earlier with the disability response teams and kind of identifying folks, we're also starting to identify and ask those questions during InReach, and identify folks who had a Medicaid waiver prior to their incarceration to see if we can get are hoping to work with our case management agencies a little bit closer to see if we can start doing some of those screenings to see if they're eligible, or if they lost their waiver because of their incarceration, if we can start working on getting it reinstated for when they get out. Just one less thing for them to have to worry about. And one more thing to kind of add to that transition of care planning on there. And so across the Intercept model, we kind of have, like I said, interventions at whichever stage, kind of moving forward. And so when we started, or when we heard about Mental Health Colorado's Care Not Cuffs initiative, we kind of looked back to see kind of what we were doing and how we share that mission with Mental Health Colorado. And so some of what we do is in kind of, like I said, shared mission is engage more individuals into healthcare services. And these are justice involved individuals. So trying to eliminate the use of the criminal justice system and really promote the healthcare system. We reduce time between jail and prison release to treatment engagement. So really looking at that access to care component still. Building collaborative and system collaboration across stakeholders, community-based organizations, and providers. And of course, we break down those systemic inequalities that stand in the way of re-entry. What we do not do with any of our programming, whether it's with the jails, probation, parole, or the prisons, is we do not provide any criminal legal representation. We are not a court ordered and not a mandated program or requirement. So we do not force individuals into treatment if they do not want it at the time, but do ensure that they know how to get a hold of us in the event that they want to explore kind of their healthcare or have questions about any other services. And make sure that they know how to get a hold of us. We are also not a siloed initiative, so we want to work with the community and collaborate in any way that we can. And we do not duplicate services within existing community programs. So again, trying to be that collaborative partner and kind of sharing what we built and how can we work with individuals with the shared mission or the shared vision. And so some of what Caroline has kind of been doing across the nation, and again, really promoting some of the work that was developed right here in Colorado, is really beginning those discussions with local administrators and county and state detention systems, the key decision makers regarding the needs and barriers of the populations that they might be working with, develop an understanding of each system's leadership, vision, and organizational culture, and develop collaborative structures and joint ownership of entry and exit processes for Medicaid members from correctional facilities, and then creating an understanding of specific data needs and challenges unique to reentry processes for the state and specifically high-need counties. And so in Colorado, we have always kind of had a larger pool of rural counties. And so really identifying and understanding some of those environmental barriers with transportation or even just with internet access in some of our counties, and then develop interventions and strategies for each involved organization so that everyone is brought into the process and aligned for success. And so really looking at Colorado with some of the work that we have done, we're hoping to work a little bit closer with the specialty courts, with the forensic navigators who have kind of built their team under the BHA, and now with the New Bridges program that is kind of getting built and developed, hoping that we might be able to kind of work with them, since I'm sure we will be sharing members who are in transition at any point of the intercept. And so this is my contact information for anyone who has questions or concerns, or after you kind of listen to this and kind of reflect and have a question, or if there's if you're within our kind of region area and didn't realize that we had all these programmings or kind of work that has been developed in maybe one of the counties that we share, also feel free to reach out to me. We can kind of see if we can either collaborate or find ways to work together. And I talk extremely fast. I should have warned you, because I get very passionate about this work and some of the work that we are doing. So I think I finished 5 minutes too early.
You're right on track, Tina. Thank you so much. We have some questions if you're ready to take them.
Sure.
The first question we have is, how could Justice Connect be expanded to individuals not in Medicaid prior to jail?
So the driver of Justice Connect, so we are able to get jail booking records. What Justice Connect does is then bump that against Medicaid behavioral claims and encounters. So if you wanted to do that for a population that was not Medicaid, we would have to have access to whatever health plan that they had billed services towards, or if they were attached to a provider and that provider was feeding that data somewhere, we would have to have access to that data for it to work. If it's someone, and we have seen individuals, and sheriffs have reached out to us for individuals who weren't from the state of Colorado, and we didn't know that, and they were really, everyone was kind of just blind to who this person was. And so yeah, that's kind of the anchor in the piece, the data piece.
Awesome. So our next question is, what are some of the hesitations with jails and facilities?
I don't think I've ever run into a sheriff or a prison that said, no, we're not interested. However, there was, because we do work with all of the prison facilities except for one, And I'm not too sure what that hesitation was in bringing some of the in-reach to that facility. But again, we don't force kind of our services on people. So as soon as they say, don't call us, we'll call you. We just ensure that they know how to get a hold of us moving forward. But I don't think I've ever had a sheriff tell me, no, we're not interested in self-sustaining this population or getting these individuals who have behavioral health needs out of our jail. It was more welcoming. And as soon as you get in with one jail and one sheriff, I mean, it just, the floodgates open.
Yeah, well, that's incredibly encouraging to hear. So our next question is there any program that would help someone who is not, oh wait, I suppose we covered that already. The similar, who'd have private insurance. That was similar to the first question. So moving on to the next one. Do you encounter many barriers to providing mental health services in DOC facilities? We have a similar questions. I guess on this one, is there ever sort of an issue with lack of providers or resources in DOC facilities, less so about hesitations and more about like the resources on the ground or in the facilities?
So some of the work that we do with the prisons when we go in, and similar to the jails, but more so with the prisons, is we're not the treatment provider. So we work with the health services administrators inside the prisons themselves. And so they're already in treatment in the prison. So we're just wanting to do that continuity of care. So if they're in a substance abuse treatment program, let's say out at Arrowhead, if they're coming to Pueblo County, if we know what their needs are sooner rather than later, we can start doing those referrals and start actually scheduling those appointments for folks getting out. So we started doing that in 2014. And I think that's why we were always able to meet that measure, is because we developed that process and that programming with our providers. Since we do a lot in the rural communities, yes, finding providers was difficult. We do a lot of education around the single case agreements and do those. So if they did have a provider who was not Medicaid, we do the outreach to see if they're willing to work with us with this one member. So they don't come into the Medicaid network. They just work with us with this one member and they're able to bill Medicaid for that service. One of the biggest barriers that still continues to this day is the transportation piece. Because even if we do have a clinician, sometimes they live 10, 15, 20 miles away. And kind of figuring out how to get them to that appointment is, I think, one of the barriers now.
Yeah, absolutely. I could see that being a significant issue, particularly as you mentioned with the rural communities. So we have another question here from someone who has a loved one in a detention center and is facing prison. They have a mental illness and substance use condition. How can they find out if their loved one is receiving appropriate care and is on medication and being cared for?
So if the so one of the it's not a nuance, but it kind of one of so Justice Connect kind of works to kind of catch those individuals to make sure if that member has Medicaid, but they're not in the HCI kind of 19 county, if they're not part of our health plan, then we don't have access to their prescription and to their Medicaid history kind of services and providers. If they are, like if that individual does like live in Pueblo, chances are that that data has already been shared with that care coordinator who's working with us in the Pueblo County Jail. They actually make contact with these individuals in the jail and kind of just go over if they are in transition. And this is something really, if they've already been kind of found guilty and have that DOC sentence, then some of the work that I do in the prison will catch them on the way out to make sure that that transition of care is happening. But if they're not our members, I'm not too sure what the other regions do with those ones, but feel free to reach out to me if you are in one of my counties and we can kind of look into if a care coordinator has already kind of reached out to that person.
Sure. And let me quickly, let's see. Tina, do you have access to the chat? I'm wondering. I'm wondering if we should drop your contact information, your email
Sure.
into the chat.
I can do that.
Amazing.
I think. Oh, there it is. I will put my email in my cell.
Oh, yeah, amazing. Oh, great. I can share that. So there is Tina's contact information for everyone, generously to offer that to all of us. Since we have a little bit of time, I figured I guess I would ask a question of my own, which is, I guess for those who are unfamiliar, Medicaid has pretty much since its inception had what is called the inmate exclusion policy, which disrupts Medicaid coverage while someone is incarcerated and for some time after their release. And this impacts the ability of the justice-involved population to receive healthcare. The Section 1115 waiver that you mentioned would waive this exclusion and allow for better continuum of care for this population. Is Colorado currently pursuing this waiver, and what impact on health outcomes would you expect to see if that waiver was approved?
So HCPF just released in October their plan to apply for the 1115 waiver. There are 4 bills currently that they are putting through the legislature, which would help build the infrastructure. So when they do apply for the 1115 waiver, they're kind of better positioned to actually implement it. And so I find myself very fortunate that our California and our Washington contracts have pulled me into those conversations. So I'm actually able to see their pain points and actually implementing this. And was really excited to see that the infrastructure that we build with Justice Connect is exactly what's going to be needed, that data sharing piece, and actually able to identify these folks. And so we'll actually be utilizing that technology in California to kind of support that. And so some of the successes that I can see is what we've already kind of seen with our regions is when you build that rapport with an individual prior to their release, then you become that trusted entity, separate from the system. So we don't come in with that stigma of being part of the criminal justice system, but as a part of your health plan and wanting to help you with that service. And so for them to turn on Medicaid 90 days prior to release from a jail or prison, they can start building that rapport with the clinicians or with those care coordinators themselves going into the prison. So we saw success with individuals not only making their first appointment within 14 to 30 days, but actually staying engaged and completing that treatment program. So we kind of look at it as in the long run of those individuals. When the BHO contracts kind of merged with the RICO contracts back in 2017, I remember I was at the penitentiary out in Fremont County right before the BHO contract ended, and we were transitioning into the RAID contracts. And I had 22 individuals who were attending that InReach kind of Medicaid event. Of the 22 individuals there, 14 of them were between the ages of 18 and 20. All of them came from the foster care system straight into the prison system. And so I remember when they got out and we were able to kind of look back at their claims and encounters, I want to say at least 12 of them were actually still engaged 6 months after their release with that treatment. And so I think that building that rapport is really impactful. And so the fact that we're going to be able to support providers going in and actually sustain that with Medicaid billing Medicaid as a sustainment for those programs, I think we're going to kind of start seeing some of those trends in the reduction of the use of criminal justice.
Yeah, which would be an amazing impact. And the final question that we have actually sort of is a very good follow-up to that question, which is, I'm presuming they mean the Colorado Department of Corrections. Does the Colorado Department of Corrections release people with medication, and for how many days?
Yeah. So they do. If it's for psychotropic medications, they get 14 days. If it's physical health, they get 30. If it's for MAT medications, I believe it used to be only 7 days worth, but I believe now they're giving them 30. But that might have just changed. But for the other ones, it has always been, and there's actually policy for Department of Corrections for psychotropics, it's within 14 days. And so that's where I think the thought process of getting them into services within 14 days is to avoid them running out or that lapse of medication happening. With Medicaid being reinstated while they're in the facility, they could also just start calling in those scripts prior to them getting out and actually having a 30, 60, 90-day supply waiting for them when they got out of the facility. So that could probably be another win in medication adherence.
Yeah, absolutely. I think it's another avenue that waiver would make a big a big difference for a lot of folks in our community. Well, I thank you so much. That is about all the time we have for questions. Thank you again, Dr. Gonzales, for sharing your time and expertise with us tonight, and for being our inaugural presenter for Care Not Cuff's Monthly Dispatch. We started off with a bang, I think. And
thank you for inviting us.
yeah. And we want to thank you all for joining us. Before we sign off, we have a few reminders for folks. If I can just share my screen really quick. Hopefully everyone can see that. There we go. We hope that you will join us again on April 25th for our next webinar, focusing on supporting those facing methamphetamine use conditions through contingency management. And we also hope that you will consider joining us for our Masquerade fundraising event, Unmasked 2024, on June 8th of this year. And you can get tickets at mentalhealthcolorado.org/unmasked2024. And finally, we just want to give another shout out to our elite sponsor of the year, Rocky Mountain Health Plans, and thank them for their support. And thank you all for a fantastic evening, and we hope to see you in April. Bye.